Now let us look at the next factor, and that happens to be factors related to GIT. So we are looking at the factors that influence the absorption of drugs from the GIT. Okay, so now we are going to talk about factors related to GIT. Okay, so the first factor that we're going to consider is surface area. Okay. So the rule that we need to, the rule of thumb that we need to remember is that the rate of absorption is directly proportional to the area of the absorbing surface. Okay. This is kind of a rule of thumb. The rate of absorption is directly proportional to the area of the absorbing surface, meaning there will be greater absorption if the area is greater, and there will be less absorption if the area is less. So that's the concept of directly proportional. Okay, so that's the rule of thumb that we need to keep in mind. So let's say a patient is administered a tablet. Okay, this is administered to a patient. Okay, so what happens is this administered drug, it goes into the stomach, and then it goes into the small intestine. Okay, so that's what happens. So the stomach, if we say, the stomach, the pH is acidic. Okay, so that's approximately 2.7. Okay, that happens to be the pH. So why is it 2.7? Right, because there are parietal cells. And what do the parietal cells do? They secrete HCl, okay, hydrochloric acid. Okay, so that's the reason why the pH is approximately 2.7. The stomach, the stomach is made up of tissues, and the tissues are now in an acidic environment. So the tissues need a protection. Okay, so in the stomach, there is a very thick mucin layer. Okay, so this mucin layer protects the tissues of the stomach from the acid. Okay, but the problem is this thick mucin layer is a barrier to absorption. Okay, so in comparison to the small intestine, less absorption takes place in the stomach. Okay. So less absorption. So what are the drugs that are absorbed in the stomach? So the drugs that are absorbed in the stomach, let's write it down here. So the drugs absorbed in the stomach would be, their property would be that they are weakly acidic. Okay, so they are weak acids. And most of them would be non-ionized. Okay, so either they are weak acids or non-ionized drugs, themselves. Okay, so weakly acidic drugs like say salicylic acid, this weak drug goes into a very acidic environment. So as a result, what happens? It does not ionize. Okay, so it remains in an non-ionized form, and in that form it gets absorbed easily. So what are the drugs? We have already cited an example: salicylic acid, and a variation of that is aspirin. That's the trade name, and the generic name would be acetyl salicylic acid. Okay, and drugs like thiopental. So these are few of the drugs which are absorbed from the stomach. But the point to remember is there is less absorption compared to the small intestine. Okay. Okay. Then the drugs reach the small intestine. Now, the small intestine is the largest section of the GIT. Okay. So it's the not largest, it's the longest. Okay. Longest section of the GIT. So the first 20 to 30 centimeters, we call it the duodenum. So the property of duodenum is that it is kind of thick-walled, and it has got a mucous membrane. And there is a gland that is found only in the duodenum, that's called Brunner's gland. Okay. So that is the property of duodenum. It's got Brunner's gland. And what does Brunner's gland do? Right, it's present in the submucosa, and it produces an alkaline secretion that neutralizes the stomach acid. Okay. Yeah, so this is present only in the duodenum. Okay. So that's the first 20 to 30 centimeters. Okay. So the point to remember here is there is again very less absorption. Okay. So there is less absorption in the duodenum. So the next section of the GIT, if this is the first section, the second section is about 2.5 meters, and that we call the jejunum. Okay. So the property of jejunum is that it has got a thicker wall in comparison to the duodenum, and it is more vascular. When we say more vascular, we basically mean that there are more capillaries and lymphatic vessels. Okay. Okay. So if it's a water-soluble drug, that would go into the capillaries, and if it's highly lipophilic, it would enter into the lymphatic system. Okay, lymphatic vessels, and then it will follow the transport of lipids but the point is it's more vascular. And most importantly, there are numerous villi. Okay, so villi are basically the absorptive surface of the small intestine, and because there are numerous villi, this is the principal site of drug absorption. Okay, so this is the place where maximum drug absorption takes place. Okay, so that is the reason why in patients who have undergone say jejunal resection. Okay, so this is in some, if you're in the UK, it would be called jejunectomy. Okay, so in patients who have undergone jejunal resection, we see that absorption is significantly reduced. And that in fact emphasizes the point that we made here, that it is the principal site of drug absorption. Okay, so yeah. So the next site, the third site, is the next 3.5 meters. Okay, and that is called ileum. Okay, and in ileum, what's there is there are less number of villi, and what is significant in the ileum is the presence of Peyer's patches. Okay. So what are Peyer's patches? They're basically lymphatic follicles. Okay. So less number of villi, meaning absorption takes place, but it's not as much as in jejunum. Okay. So as far as drug absorption is concerned, the jejunum happens to be the primary site. Okay, all right. So in summary, as far as surface area is concerned, we remember that the rate of absorption is directly proportional to the area of the absorbing surface. And we have noted that the maximal surface, absorbing surface is found in the jejunum. Okay, why? Because if you look at it, there are numerous villi. Okay, there are numerous, if these are villi, there are numerous villi, and they are kind of folded. Okay, so the membrane is folded. Now if the membrane is folded, what happens? The surface area increases. Okay, so suppose you have a cube, and the same volume you make a sphere. Okay, the sphere would have greater surface area. So anything that is kind of rounded has got increased surface area. And so that's the reason why in that limited length of the jejunum, the surface area is massive. And that's the reason why there is maximum absorption. Okay, and the other point to remember is the stomach, only few drugs which are weakly acidic or non-ionized, they are absorbed in the stomach, but for all intents and purposes, maximum absorption takes place in the small intestine, and specifically in the jejunum region of the small intestine. Okay. Let's look at the second factor related to GIT, which is the pH of GIT. Okay. Sorry for that. Okay, so the second point that we're going to look at is the pH of GIT. So let's remind ourselves again where we are now. We are talking about the absorption of drugs from the GIT. We're looking at factors related to GIT. We covered surface area. And now we are looking at pH of GIT. Okay. So let's bring it up here. Okay. So when we talked about the transport, we talked about passive diffusion. Okay. So passive transport of drugs across the membrane of the GIT of ionic drugs. Okay. So by passive transport we mean transport which does not require ATP. Okay, so that's our definition of a passive transport. So passive transport we said is dependent on the concentration gradient. So passive transport across the membrane of ionic drugs, okay, is dependent on the degree of ionization, okay. So passive transport of ionic drugs across the membrane is dependent on the degree of ionization. So more the degree of ionization, less is the absorption. So let's write it down somewhere here as a rule of thumb. Ionization is inversely proportional to absorption. Okay, so the more a drug is ionized, the less it is absorbed. Okay, so that's the rule of thumb there. Okay, so the passive transport across the membrane of ionic drugs depends on the degree of ionization. And this degree of ionization depends on the pH. Depends on the pH of the area where absorption is taking place, okay? Where absorption happens. Okay? So pharmaceutically, there are two types of drugs which are ionizable, which are of interest with regards to the degree of ionization. And the first one is weak acids. Okay, so let's talk about the general formula of a weak acid. So the general formula would be this, and a weak acid would be in equilibrium like this. Okay. Okay. So a weak acid would exist as in its ionic form as well as the non-ionic form. This is non-ionic. And this is ionic form. Okay, so this weak acid would be in equilibrium like this. Okay, now the property of a drug in equilibrium like that is defined by something called the pKa. Okay, so the pKa would be listed for drugs like, for example, let's take the example of a weak acid and explain. For example, aspirin. Okay, aspirin has got a pKa of about 3.5. Okay, so for weak acids, if the pKa is less than um, um, no, if the pKa say is greater, sorry, let me just write it down again. Okay, so if the pH, let's talk about the pH because we're talking about the pH. Let's put that first. If the pH is less than pKa, then the equilibrium would be shifted to the left. Okay. Like so. The equilibrium would be shifted in that direction. Now, if that happens, what's going to happen at a pH less than the pKa, let's say in the stomach, where we have a pH of approximately 2.7 on an average. So that pH is less than pKa, it's less than 3.5. So in this case, what's going to happen is there's going to be an increased concentration of aspirin in the non-ionic form. As a result, there would be increased absorption in the stomach. Okay, so there are lots of weak acids like this. Let's look at some examples. So the first one that we talked about is aspirin. There are other drugs, and let's have a brief list of those drugs. Theophylline, levodopa, amoxycillin, the beta-lactam, cephalexin, the diuretic frusemide, the anticoagulant warfarin, phenytoin, which is anti-epileptic, and acetazolamide. That's again a diuretic. So these are the common drugs which are weak acids. They can get absorbed in the stomach. So what about weak bases? So if it's a weak base, okay, so let's represent a general formula. So the equilibrium would be so. Okay. So B would be a base in presence of water, obviously in the GIT. There would be this ionic species and the non-ionized form. Now, if the pH, again, similar to the one above, if pH is less than pKa, then in case of weak bases, the equilibrium would be shifted to the right, okay, like so. Okay. So the equilibrium would be shifted to the right. Meaning there would be more ionized species present. As a result, absorption would decrease. Okay, so imagine the case that the base is in the acid medium of the stomach. So because this is a weak base, obviously the pH would be less than the pKa, and then what would happen is the weak base would be ionized. As a result, it won't be absorbed in the stomach. Okay. So intuitively, if we think about it, that the pH in the intestine, which is ranges from 6 to 7.4, this is in the duodenum, and 7.4 at the level of the ileum. Okay, so at this pH, what's going to happen is it is greater than the pKa. Okay, as a result, the equilibrium would be shifting to the left. As a result, the weak base would be in a non-ionized form, and it would be easily absorbed. Okay. All right. So, what could be examples of weak bases which are important clinically? Let's again list some of those drugs. There is this drug lignocaine, codeine, adrenaline, amphetamine, atropine, metoprolol, methyldopa. Okay, there are lots of examples. We have listed just a few of them here. Okay. So the prototype example could be, let's write it, diazepam. Okay. So, yeah, diazepam would have a pKa of about 3. Okay. So, in the stomach it would be ionized, and the intestine, because the pH is 6 to 7.4, it would be non-ionized in the intestine. As a result, it would be absorbed in the intestine. Okay. But there is a small caveat that we need to remember. Though what we mentioned about absorption in the stomach is true, we also need to consider the surface area. Okay. Now, surface area of the stomach is about 1 meter square, whereas the small intestine, the surface area is about 200 meters square. Okay. So as a result, even these drugs get absorbed in the intestine. Okay, because the surface area is greater than that of the stomach. Okay, so aspirin, though we say it is absorbed in the stomach, considerable amount of aspirin is absorbed in the small intestine as well. That's to do with the difference in the surface area. Okay, so small intestine has got a greater surface area. So we need to remember this caveat when we talk about the effect of pH on absorption of drugs. Let's look at the next point. And the next point is gastric motility. Okay. The rule of thumb is that absorption is directly proportional to the motility rate. Okay, and and it is directly proportional to the emptying rate. Okay, so let's see what this means. So the idea is we have got the stomach, and from the stomach the drug enters into the intestine. Okay, so if suppose the motility of the stomach is greater, what's going to happen is there is going to be faster emptying. Okay, and faster emptying would mean that the drugs are reaching this large area of the small intestine of approximately 200 meters square, it's reaching that area faster. Now, if it reaches that area faster, obviously there would be faster absorption. Okay, so therefore we have this rule of thumb. Okay, so absorption is directly proportional to the motility rate and directly proportional to the emptying rate. But this is within physiological limits. Okay. Now, if there is massive increase in motility, for example, diarrhea, then the absorption would be reduced. Okay. And if the emptying time is reduced, for example, in the presence of drugs like atropine, okay? Atropine, what does it do? It decreases emptying time. Okay, as a result, less drug would reach the intestine. Okay, so therefore atropine can reduce the emptying time. On the other hand, if there is a drug which increases the GI motility, like metoclopramide, okay, so this basically increases gastric motility, Okay, as a result, the gastric transit time will reduce. As a result, absorption of drugs like digitalis will reduce. Okay. So GI motility has got important bearing on the absorption from the GI tract. Okay. So let's look at the next point. The next point is local blood flow. Okay. In this aspect, we need to understand the rule of thumb would be where there is increased blood flow. Okay. Wherever there is increased blood flow within the GIT, so this increased blood flow would imply increased number of blood vessels. Okay. Okay. So if there are increased number of blood vessels, it means lipid soluble drugs. Lipid soluble drugs will be absorbed faster. Okay. So that's the rule of thumb. Okay. So wherever there is increased blood flow, it would imply increased number of blood vessels, and which in turn results in lipid soluble drugs being absorbed faster. So where do we have rich blood flow? We have it in the jejunum. Remember, we have got villi there. What about the buccal mucosa? Okay, so buccal mucosa and the sublingual area. Okay, all those places we have got numerous blood vessels. As a result, drugs like sorbitrate, for the buccal we have drugs like sorbitrate, okay, basically glyceryl trinitrate, nifedipine, and the painkillers, say buprenorphine. Okay, so these drugs are highly lipid soluble, and therefore they can be administered by the buccal or sublingual route. Okay, so the reason being, these areas there is lots of blood vessels. As a result, it can directly enter into the blood vessels and then bypass the liver. Okay, so it can there can be greater systemic bioavailability. We would visit this point when we talk about bioavailability. Okay, and jejunum. Okay, lots of drugs are absorbed in the jejunum because there are lots of blood vessels. Local blood flow also determines the rate of absorption of drugs from the GIT. Okay, let's visit the next point, which is the presence of food or other substances. Okay, So let's take an example of a food, say milk. Okay. So milk has got calcium. Okay. And this calcium can chelate certain drugs. Okay. So calcium can chelate certain drugs. What could be an example? An example could be tetracycline. Okay. So as a result, what would happen? This would form a complex. Okay. And this complex will not be absorbed. Okay, so you're giving a patient, say the patient has got acne. What's acne? Right, pimples. Okay, and for pimples you've got a bacteria, which is Propionibacterium acnes. Bacterium acnes. Okay, so this is the organism that brings about inflammation in the pimples. So now you're giving tetracycline. You're giving tetracycline as a drug to counteract this bacteria. But what happens? You are concurrently drinking milk. You're taking tetracycline with milk. So as a result, what's going to happen is the calcium in the milk is going to complex with the tetracycline and forms a complex. As a result, tetracycline will not be absorbed. Now, if tetracycline is not absorbed, what's going to happen? Its effect on the pimples is going to reduce. So there can be a therapeutic failure. So the presence of food has got a bearing in that it can form a complex. So food can form a complex with the drug, or it can dilute the drug. Remember we said passive absorption, we need a concentration gradient. So greater the concentration, greater the absorption. Now if you dilute the drug, the concentration would decrease. Now if the concentration decreases, absorption will be slower. Okay? And milk is an emulsion. Okay? It's a water, oil in water emulsion. Okay? Meaning fat droplets are suspended in water. That's what milk is. So if we observe milk under a microscope, we're going to see fat droplets. Okay. Now this fat has got this property that it can delay gastric emptying. Okay. So fatty foods can delay gastric emptying. Okay. So if gastric emptying decreases, what's going to happen? The drug will reach the small intestine very slowly. As a result, the absorption rate would again decrease. Okay, so foods can also. So these are the three general mechanisms by which food alters the absorption. Okay, some food forms complex with the drugs, some dilute the drug, and some delay gastric emptying. Okay, but it has got a flip side too. Now there are drugs like griseofulvin. Okay, so griseofulvin is basically an antifungal drug, and this drug, the absorption of griseofulvin increases in the presence of fatty food. Okay, so if fat is present, contrary to what we talked about here, lipid-soluble drugs like griseofulvin, the absorption is increased in the presence of fatty food. Okay, and fatty food has got another role. Fatty foods, they can increase bile salt secretion. Okay, so now bile salts, what does it do? It emulsifies the fats. As a result, there will be increased absorption into the lymphatic blood vessels. Okay, so fatty drugs, fat soluble or lipid soluble drugs in the presence of fatty foods show increased absorption. Okay, the reason being, the indirect reason being that fatty food increases bile salt secretion, which emulsifies the fats, and there is increased absorption. Okay. Similarly, similar to griseofulvin, fatty foods can increase the absorption of propranolol. Okay, so these are more lipid-soluble drugs, metoprolol and chloroquine. Okay. On the other hand, let's look at, say, someone is consuming liquid paraffin. Okay, paraffin for maybe constipation. Okay, so liquid paraffin the person is taking to bring about laxation. Okay, but this liquid paraffin, it is a mineral oil. Okay, and this mineral oil, because it is not a fat, it's a hydrocarbon, it cannot be emulsified by the bile salts. Okay, so as a result, mineral oil generally is not absorbed in the body. But what the mineral oil does is it acts as a solvent for fat soluble vitamins. Okay, so mineral oils can act as a solvent for fat soluble vitamins. Okay, so which are the fat soluble vitamins? A, D, E, and K. Okay, so what's going to happen is this mineral oil can solubilize these vitamins which are present in the intestine as a result of you consuming food. Okay, and then what would happen is this mineral oil, as we said that it is not absorbed, it would be passed out of the GIT, taking away with it these vitamins. Okay, so again, the absorption of vitamins. So if you're concurrently taking vitamin supplements along with liquid paraffin, then the absorption of those vitamins would be compromised. Okay. So all in all, we have talked about the presence of food. The other important example when we talk about calcium is calcium-containing drugs. Okay, or divalent ion-containing drugs. Which are they? So the important divalent ions which are not absorbed are magnesium and calcium. Okay, so the drugs that contain magnesium and calcium are antacids. Okay, so these divalent ions, as we talked about for milk, they can complex with drugs like tetracyclines. So not only food, even drugs, okay, like antacids can interfere with the absorption. All right? Okay. Let's visit the next point, which is enterohepatic recirculation. Okay. So it's enterohepatic. Okay. So entero means intestine. Hepatic means liver. Recirculation. Okay, meaning there is a recirculation. So let's understand what this means. Now, as far as our body is concerned, we put water-soluble drugs. Okay, having little bit of lipid solubility, only those drugs would enter into the body. But basic property of the drug being they are water soluble. So what happens is the body excretes them. Okay, excretes through the kidney. Okay, and sometimes what the body does is it takes it to the liver and then metabolizes it, and then the metabolite is excreted through the kidney. Okay. So this is what usually happens to water soluble drugs. But if it is a lipid soluble, okay, then excretion through the kidney is not easy. Okay, so excretion through the kidney for lipid soluble drugs is not easy. So what does the body do is, the body takes this lipid soluble drugs into the liver and it adds certain chemicals to it. Okay, that is metabolism phase 2. Okay, meaning it conjugates certain other chemicals to the lipid soluble drug and then makes it water soluble. Okay, excretes a part through the kidney and excretes a part through the bile. Okay, so the bile and bile salts, they enter into the sea of the duodenum. So if that's the duodenum, the hepatopancreatic duct, okay, the hepatopancreatic duct enters into somewhere in the sea of the duodenum. Okay, the hepatopancreatic duct opens into the duodenum. So what happens is, these conjugated drugs get into the hepatopancreatic duct, reaches the duodenum, and then it is excreted out of the out through the GIT, through the feces it is excreted. Okay, in an ideal world this is what should happen. Okay, but what happens is, the drug which gets conjugated, the conjugated drug, okay, usually it is conjugated to glucuronide. So the glucuronide conjugated drug reaches the intestine, and in the intestine there is bacteria. Okay, okay, so what did we say? The conjugated drug is lipid soluble. Okay, I mean the initial drug was lipid soluble. By conjugation, the conjugated drug is water soluble. Okay, so this water soluble drug has come into the intestine, but what's happened is, there is bacteria, and these bacteria have got glucuronidase. Sorry, I messed up my spelling. Okay, so glucuronidase. Okay, so ACE, it's an enzyme. Okay, so what it does is, this bacteria in the colon, the normal bacteria which are present in the colon, produce this enzyme glucuronidase. This glucuronidase act on the glucuronide conjugated drug, and then it breaks down the conjugation. Okay, so there was a drug that was conjugated to glucuronide, and the glucuronidase acts on this drug conjugate and converts it into drug plus glucuronide. Okay, so what was the drug's property? The drug was lipophilic. Okay, and by conjugation it became water soluble. Okay, and now this glucuronidase removed the glucuronide part of it, which makes this drug again lipophilic. And because it is lipophilic, what happens? The lipophilic drug gets reabsorbed. Okay. Again it reaches the blood and now it is lipophilic. From the blood it goes into the liver. The liver again conjugates it and then this cycle continues. Okay. So that is why we call it recirculation. Okay. The drug kind of flows in a cycle. Okay. And this whole process we call it enterohepatic recirculation. Now, because of enterohepatic recirculation, some drugs have got a long T-half, long half-life, meaning they remain in the body for a very long period of time because of enterohepatic recirculation. Okay, so the drugs which undergo enterohepatic recirculation, let's list the name of some drugs. These drugs, indomethacin, okay, calciferol, say doxycycline, vitamin B12, folic acid. Okay, remember this is given to pregnant women as a supplement. Then oral contraceptives, rifampicin. Okay. So the common property of all these drugs are that they are highly lipid soluble. Okay. And these drugs because of enterohepatic recirculation have got a long T-half. Okay. Now, when we remember, we need to remember a caveat here. Okay. So what did we say? The microbiome, okay, in the gut. The gut microbiome is the population of bacteria which is normally present in the body, which produces this deconjugating enzymes. Okay, and those deconjugating enzymes are basically responsible for most of the enterohepatic recirculation. Okay, so we are now specifically talking about glucuronidation. Okay, now if suppose a person is taking an antibiotic, okay, a broad spectrum antibiotic, okay, say tetracycline or so, okay, has taken a broad spectrum antibiotic. So this antibiotic is meant to kill the microbes which are which are pathogenic. But in addition to killing the pathogenic bacteria, this antibiotic sometimes also kills the gut microbiome. Now, if it kills the gut microbiome, what's going to happen? There won't be deconjugation reaction. As a result, what's going to happen? These conjugated drugs will not be reabsorbed. It will go through the feces. Okay. Now, suppose the patient has taken, say, tetracycline along with oral contraceptives. Okay. So these oral contraceptives are meant to be in the blood for a very long period of time, and it essentially undergoes enterohepatic recirculation. But because we gave this antibiotic, it might interfere with the enterohepatic recirculation of oral contraceptives. As a result, the concentration of the estrogen, the progesterone in the female body might reduce. As a result, there can be potential contraceptive failure even. Okay, so that is something that we need to keep in mind. Okay, when we talk about enterohepatic recirculation. Okay, so there can be potential drug interactions which can reduce enterohepatic recirculation. Okay, so that's what we need to remember when we talk about enterohepatic recirculation. Okay, which brings us to the last point here, which is the diseases. Okay, so certain systemic diseases, and diseases of the GIT Okay, this can interfere with absorption. Okay, for example, if a person has got congestive cardiac failure, okay, so what's going to happen? Because of congestive cardiac failure, there will be decreased blood flow. Now, there will be decreased blood flow to the places where there is increased blood vessels. Okay, so the mucosa or the jejunum, there will be decreased blood flow. Okay. Now, if there is decreased blood flow, there will be decreased absorption. Okay, so most of the drugs would be affected if the person has got congestive cardiac failure. Okay, so localized delivery should be looked at. Okay, in such patients. Okay, and sometimes even the decreased blood flow, we need to remember in the jejunum and GIT, that's the splanchnic circulation. Okay, splanchnic circulation decreases. Okay, and then certain diseases of the GIT, like say what could be an example? It could be achlorhydria. Okay, meaning the stomach is not producing HCl. So if there is a drug that is getting absorbed in the stomach, it won't be absorbed in the stomach. Okay, or there can be pyloric stenosis. Okay, so stenosis is basically contraction of the pylorus, as a result the emptying time. Okay, emptying time will be compromised. As a result, absorption might slow down. Okay, or there can be maybe some type of malabsorption syndromes. Okay, all this can reduce the absorption of drugs from the GIT. And even surgery. Okay, so when we talk about systemic diseases of the GIT, the other point could be even surgical corrections. Okay, like jejunostomy, which we covered earlier, but just keep in mind in this context. Okay, so even surgical interventions can also interfere with the absorption of drugs. Okay, so in this lecture, we have talked about the factor related to the GIT. Okay, we have seen the factors related to the GIT which affect the absorption of drugs from the GIT. We talked about surface area, we talked about pH, we talked about GI motility, we talked about the local blood flow, we talked about the presence of food or other substances, we talked about enterohepatic recirculation, and we talked about the effect of diseases on which might interfere with the absorption of drugs from the GIT. Okay, so that in essence completes this section of our lecture on pharmacokinetics, the absorption of drugs from the GIT. Okay, so we would be now looking at other absorption sites. Okay, so in this we have talked only about absorption of drugs from the GIT. Okay, there we will be looking at other sites in a subsequent lecture. Thank you for your attention.